We now move on to our next session on errors in medical practice, what can go wrong. As per the Institute of Medicine, an error is defined as the failure of a planned action to be completed as intended, which also known as the error of execution, or the use of a wrong plan to achieve an aim, which is the error of planning, or failure to do something that ought to be done, which is the error of omission. Medical errors occur in nearly 10% of hospitalizations, which lead to avoidable morbidity and mortality among patients. Errors are inevitable in the practice of medicine owing to the human factor, some of which are memory, knowledge, judgment, and skill. As healthcare is continuously evolving and is becoming more complex, it is logical to assume that such errors need to be addressed promptly.
To deliberate upon the topic, we welcome our next keynote speaker, Lieutenant General Velu Nair, Param Vashisht Seva Medal, Ati Vashisht Seva Medal, Vashisht Seva Medal, Bar, the DGMS Army, and Colonel Commandant. So can you please take a seat on the stage? Thank you. Next, I invite the panelists to join the chairperson on the stage. Firstly, Justice Vinod Gupta, former Chief Justice, Jharkhand, Himachal Pradesh, and Uttarakhand. Dr. B.K. Rao, Chairman and Senior Consultant, Critical Care at Sir Gangaram Hospital, New Delhi. Dr. Anupam Sibbal, Senior Consultant, Pediatric Gastroenterology and Hepatology, Indraprasth Apollo Hospitals, and Group Medical Director, Apollo Hospitals. Brigadier Rashmi Datta, Vashisht Seva Medal, Consultant Anesthesia at Base Hospital, Delhi Cant. Dr. Girish Tyagi, Registrar, Delhi Medical Council. And finally, we invite Dr. Aarti Verma, Senior Vice President, Medical Quality at Max Healthcare, New Delhi, onto the stage. General Velu Nair, DGMS Army, is an alumnus of the AFMC Pune, where he did his undergraduation as well as post-graduation in internal medicine. He later completed postdoctoral fellowship in hematology and bone marrow transplant from CMC Vellore and King's College London. He holds a visiting professorship from Stanford Medical Center, USA. He is credited with establishment of the first Department of Clinical Hematology and Bone Marrow Transplant, and is the recipient of numerous awards in the field of medicine and medical education. He has served as a professor and head Department of Medicine at AFMC Pune, and has also been the Dean of Armed Forces Medical College Pune and Army College of Medical Sciences, New Delhi. He has more than 252 publications in various journals and books to his name. Now I request you to kindly deliver the keynote address for the session, sir.
Good afternoon, ladies and gentlemen. I'm actually delighted to be here to actually take part in a very important session for, I would say, all doctors and stakeholders involved with the healthcare industry. And I'd like to thank the organizers, especially Dr. Shakti Kumar Gupta and Dr. Siddharth Satpathy, and the AIIMS Department of Hospital Administration, the Research Foundation of Hospital Administration, for having put together this conclave on very important aspects not often spoken about. And I think that's so essential that it was far in between that you had a conference even on patient safety. And I'm happy to see that over the years, certain hospitals in the public and private sector have taken the lead. Apollo had did a wonderful one the last few years, and it became a yearly event. And I've seen NABH taking the lead. And of course, such conclaves are actually very, very important to bring about the sensitization to the medical fraternity at large and the public also. With that little preamble, I think I'll go on to the business end of my talk. And I'm going to keep, it's impossible to cover things in 10 to 12 minutes, so I'm going to touch on a few relevant things and go a little fast because obviously, there's been enough of sessions covering most of the things that I'm going to say, I think. There's hardly a week which goes past when you don't refer to medical errors in some form in the print and electronic media. And whether it's India or abroad, it's not any different. And this document has been spoken about, I'm sure, many times. To err is human, from the IOM, which is the Institute of Medicine, which is a private non-profit organization that provides health policy advice, but under a congressional charter, which gives you credibility. That's the most important part. And it's been granted to the parent body, whether it's the National Academy of Sciences. People say 7.5%, 10%, some countries will go on to say 13%. The design of reporting itself is different. That will throw up different figures. So there is no sacrosanct figure here. It's not yet standardized, I would say, even the reporting system. Whether it's Europe, whether it's North America, we are far from it anyway. So I would say, suffice it to say that anywhere between 10 to 15%, this is also underreported. But definitely, you must know there are certain special groups who are more prone to this. That's people in the ICU, the patient in the ICU, operation rooms, and the accident and emergency department, where action, monitoring, handoffs take place frequently, and that's where mistakes occur. And now the proportion is rather epidemic, and it's a global phenomena. But what's important is not that it's a global phenomena. What's important is the response to this phenomena. The response is much more fast and rapid, I would say, in the Western world because of accountability, and it's much more tardy in our part. And sometimes it's not even there. So that's the difference we have to take note of. I just told you about the burden. But what's important is what is the preventable component of this burden. And that's what's shown here. You see that 50 to 70% of this can actually be eminently prevented. And that's what we have to work on. It's a sizable number. And it's not easy to define medical errors. We may put together different definitions, but if you really see, it's not easy. And a medical error can be an act of omission or commission related to healthcare, and it obviously contributes to an unintended health result. That's the important part. And this was formulated in 2005. And to go on to say that any preventable event that may cause or lead to an inappropriate medication use or patient harm, while the medication is in the control of the healthcare professional, patient or consumer. Now the last two words, patient or consumer, we very often don't take into account. We only talk of the doctor and the healthcare industry, the doctors, the nurses, and so on and so forth. We forget these two. And the error is the failure to carry out a planned action as intended or the application of an incorrect plan. So you can see the canvas can keep widening, okay? The types, now when we always talk of medical errors and medication errors, they're not synonymous. Medication errors are the medicines you're actually giving the patient. Medical errors will cover all this, from diagnostics to preventive. Have you failed to give thromboprophylaxis in a situation where DVT is going to occur? That's a medical error. And of course, more subtle soft skills, failure of communication, which is one of the major reasons, equipment failure, infrastructure failure, administrative failure, all that will come into errors which are in support of the healthcare delivery system. And medication errors may just restrict yourself to the drugs. Okay, if you want to further classify them, you can actually say, okay, I want to see the outcome specific errors, which actually will tell you which is the bulk of the proportion belongs to which of these categories. Is it specialty specific? I'm much more in hem-onc, and it's least in chest medicine or respiratory medicine. And then you look for specifics. We only talk of inpatients, not knowing that many occur in the outpatients, in the community healthcare centers. And what I wanted to see is the bottom line. The bottom box says nursing home. What's happened here? Anyway, nursing homes, polyclinics, pharmacies, and patient-related. Okay? And this is often neglected. In our country, healthcare, public and private, as you know, the proportion has been shifting. It's more towards the private sector now. And the public sectors very often are not able to cope with it. But at the same time, we do not audit or take into account nursing homes, polyclinics, pharmacies are one of the biggest culprits. Over the counter medicines, which you can go and buy anything you want, and patient related. Okay. How dangerous is medical errors? Let me just tell you, it's more dangerous than many of the things we know. It's more dangerous than road traffic accidents. It's more dangerous than adventurous sports. It's more dangerous than even a gun-trotting country like in the US, because they are much more in frequency. And why do they occur? We know mistakes will occur. The question is, what do you do about a mistake? How do you account for it? How do you do the feedback loop? How do you audit it? And how do you implement this whole loop is what's important. Errors will occur as long as we are there. And what's important is, with more complex medicine, super specialties coming to being, obviously the whole thing gets more complex. But what's most important is, we never see the root cause. We always tend to blame the individual. It's he or she or a doctor or a nursing officer. We forget that it's by and large a system failure. And the system has set it up. And if you really go into it, he's been working for 18 hours, 3 days a week. And something goes wrong and you still say the system. But the system has not taken care of his work hours. The fatigue syndrome. Likewise, you can go on, but the system failure needs to be looked into. So the response, you have to say, how do you strategize? So I looked at the zero error. Let me just first finish off this famous document, IOM, which was, I think, very overrated, criticized, debated no end, and it was an estimate. But the whole world went berserk on that estimate, saying, okay, 44 to 98,000 die. Words used were at least, perhaps. And we said, that's sacrosanct. But that's not how you work on a model, especially if you're working on a business model. But then they said, okay, let's take stock after 5 years. 2004, they took stock of the report. They said we should decrease the errors by 50%. It didn't happen. It may never happen. Because we don't know how to even audit and record those errors, because there are different grades and severity of errors. All that was not even put on or conceptualized when this document was written. The key factors then they found is that you have a fragmented and decentralized health system. A patient comes from a community health center to a secondary care hospital, then to a tertiary care hospital. The documentation, the handing overs, and the vital parameters all along with the medications taken are not even handed over properly, or you're not even recorded. So an incomplete, recorded patient with backups comes to a tertiary care hospital, and they're supposed to do a magic. And if they don't do the magic, he's liable to a litigation, or at least there's an attempt to, saying he's come to the top level hospital and the patient's died, but not realizing he was already not there when he came to you. Now what they said is, nothing comes for free. You give peanuts, you get monkeys. There's no doubt about that. So they said you have to spend in millions, and they said 25 to 35 per year, going up to 100 million in 5 years, and you may actually have an agency to do what you want to do. But if you don't do that, you are actually losing in millions. They estimated, anywhere between 17 to 29 billion dollars was being lost yearly on what stats that IOM brought out. And you had to spend only in millions to save these billions. Okay, so the 4-tiered strategy was to have a cell, which in America they called it the Patient Safety Center for Agency Healthcare Research and Quality, error reporting systems, performance standards, and safety systems. Okay, and this is what the center looked after essentially, which we will talk about. Now, I just looked at the zero error system. We just had a big conference on aerospace medicine organized by the DGMS Air, and I chaired a session on safety, okay? Now, they do have a zero error. And when you get into a plane, how often do you think I'm not going to reach there? You never think. You think everything's tickety-boo. That's how it is. So I just went for this crazy Sukhoi flight in Tezpur just about a few weeks ago. It took 3.5 hours on the simulator through all I was a passenger on a trainer aircraft. But 3.5 hours to put me through all the reading instruments. Unless I cleared them, I was not cleared for the flight. Then the checklist went through, and after I went through 3.5 training, we went on the Sukhoi, and after we came back after nearly 45 minutes of flying, there was a checklist to be again gone through. The debrief. And each one was gone through and saying, was there a slip up? So it was a lesson for a doctor who thought he was there. And I just see how often do we get into a surgery saying, okay, I don't have that instrument, but I think I can get away with it. It's okay. I'm so experienced. I'm a prof. So let's go for it. No problem. How often do I delay an elective surgery? It's different for an emergency surgery. I'm talking of electives. But there is hardly ever a turn back. It's always saying ad hocism that we go for it. And that's a system failure for me, not a doctor's failure. He ends up with a complication. He's a stakeholder in that complication. But it was not provided what he wanted. So the first thing is training. And we have enough simulator training in our medicals, which they do, we can also do. I've got analogies for you here. And in FMC, we really actually, spend a lot of time on this. And let me tell you, that's good money spent. It goes into crores. We want the right mannequins and the software to actually create situations of a cardiac arrhythmia and so on and so forth. Then you come to the checklist. He will never take off till the checklist is correct. Technical snag, he will not take off. And that's the way to go. And on the checklist, this is a very simple checklist, which time and again many institutes have given. There are overlapping things. But by and large, if you do these 9, you are by and large there. There will be still more to add, but this won't be a bad starter. Let me just show you the surgical, we just talked about, swabs left in the abdomen after surgery. Just see this checklist of surgical outcomes when they actually have done a checklist. So you can see the taller bars and when they did not do, and the darker bars are when they did. And you can see the difference. The deaths and complications, everything significantly came down when you did a checklist. So there's no escape on this. You just have to do it. Teamwork is so important. So you can't be a solo. I'm the only surgeon. The team leader takes the responsibility, but each stakeholder is on board. That's the important part. And then this part, what are we going to do at the end of it? How did it go? What went wrong? What we could have done about it? So it should be all transparent. And I can tell you, it's actually much more simple if you do these things, that you will prevent things. And then when you have a reporting, mandatory versus voluntary reporting. Mandatory reporting, in Hindi they say, like a dictator. It's there, you got to do it. Voluntary reporting, a doctor would love to report if he's protected. But if you don't have the regulations in place, I'm subject to a subpoena or even a litigation. So you have to have the system to protect him, to report voluntarily. So you can't just say, please report voluntarily. You've got to have the systems in place. Now, standardization is more easily said than done. You see the panels, you take the Boeings and the Airbus, a conversion occurs when he has to change planes. And the conversion is standardization, getting used to the instrumentations. And here, all the aircraft industries have made it so simple that there is a common denominator. And the other ones which are not common, you can actually do in the conversion course. Do we have the same? I don't think so. Now, I brought this slide on demonetization of medical errors. It sounds crazy. But you know what? Like there was a black economy for which our Honorable Prime Minister actually did a surgical strike. I think we have to do a surgical strike on certain parts to prevent medical errors. And one is this over the counter where the pharmacist is the doctor and the patient is half a doctor. I want an antibiotic. He gives you 3 antibiotics and you choose one. You ask for any drug, you can get it today. You know it and I know it. But is that the way to go? It's unmonitored, unregulated, and there's no data. Forget about ADR and AES. We don't even have a prescription. So it's worse than a black economy in health, as far as I'm concerned. And so we need to strike here. We need to have mandatory prescription dispensing. It should be regulated, audited, and there should be legal agencies to punish people who default here. Otherwise, we are not going to get to it. Now, you see these two. You see a private sector hospital pharmacy, okay? And this is in every gully of a nook and corner of our country, where a untrained, very often not even licensed, one pharmacist has got 4 pharmacies, and he's selling medicines. So, this is how it goes. Each capsule contains your medication, and you can do it. Lhasa, we actually don't even have in the industry, to look alike and sound alike. It's there, and you just have to suffer it. And you can go on and on. And this you can extend to our doctor's handwritings, prescription writing, where it says 1 tablet 3 times a day. and it is digoxin, but what's taken is digoxin. What is dispensed is digoxin. Even the patient comes with heart blocks. So this is bound to happen if you don't have proper prescription writing, computerized forms of writing, and obviously the other things that I've told you. So if you can't do any good, please don't do any harm. And have the right patient safety fora, conclaves to actually sensitize the people concerned. And on the death certificate, we have ICD codes, but there's nothing for medical errors. Even it's very clear that he died of a medical error. Yeah, thank you. He said, I got 2 minutes. So the 4 key factors contributing to epidemic of errors are, I just told you, fragmented system, licensing and accreditation, which in our country is a voluntary form, medical liability system, malpractice litigation, and limited incentives for improvements, especially when you have insurance companies, okay? And this I've gone through. This also we can skip. So this I want to say that the Indian Medical Council regulations 2002 empowers the MCI and respective state medical councils to punish an erring doctor against any act in violation of the code of ethics and illegal trade practices. Medicine is a state subject, but doesn't mean that the central or a federal involvement cannot be there. It has to be there. And it has to be a multi-pronged effect, and we as doctors also have a role. Cases with regard to complaints against medical negligence by professionals are adjudicated by the ethics committee of the MCI, and accordingly information is regard is maintained by the MCI. Okay? National initiatives, NABH. I think all of you are aware of it, and AIMS is anyway conducting this conclave. And the standards are elucidated, and actually many people are familiar, but most, I will still say, are not, including hospitals. This is one of the latest, 2010, I think, pharmacovigilance program of India called PVPI, located in Ghaziabad, an initiative of the CDSCO or DCGI under the aegis of the MOH. And here, ADRs are reported all over the country to a national coronary center in Ghaziabad, and this works in collaboration with the global ADR monitoring center in Sweden. And I must say at the end of it, that all this can be there. But if you're not involved, nothing's going to happen. And for your involvement, you obviously have to take your whole team into be involved. And with the team, don't forget the most important person is the patient whom the team is dealing with. And that patient has to be taken right along with you on board regarding all the issues that have happened. And awareness of the patient will help you a lot. And a complete submission of the treatments he's undergoing is equally important. So wise people learn from others' mistakes. Fools learn from their own mistakes. We can choose to be wise or to be fools. Thank you very much, ladies and gentlemen. I think I saw most of you not sleeping. That's a good sign. Thank you.
Thank you so much, General Velu Nair. And it's really a privilege to be sitting next to you, a senior from college. And I must share that as DGMS Army, he leads how many hospitals in the country?
111 peace hospitals and 99 field hospitals.
So and you know, the Army, I think, is a fantastic example of standardization, training, regulation, and I'm sure it would be very interesting to do a study to see, you know, the quantum of errors that you all face versus a more dynamic and less regulated public hospital or a private hospital would face. It would be an interesting comparison. But thank you so much. You've done real justice to a very important subject. So when we talk about medical errors, we you know, I wear a quality hat, so I don't want to look at legal issues so much as I want to look at system issues. And General Nair has brought it out very nicely. We have a panel of esteemed experts here who are a mix from providers in the industry as well as from the regulators. So we'll have a nice mix of questions for them. I'd like to start with Dr. Anupam Sibal, who is also you know, doing a fantastic job as Group Medical Director. And we hear so much of such good things about, you know, all the safety initiatives you take across the chain of Apollo hospitals. So Dr. Anupam, would you like to share a little more in depth about what constitutes a medical error in a hospital treatment procedure versus, you know, a complication? How would you differentiate between making it an error or a complication? And please go on to also share with us for the benefit of the teams here, what are the 5 top priority actions that any provider organization should take, given your experience in the Indian context, to reduce the burden of errors in our highly complex environment?
Thank you very much for this opportunity. I'd like to thank Shakti ji, Vijay ji, and Siddharth ji for organizing this fantastic conference. What amazing faculty and what clarity with the sessions and 3 days of deliberation. So you really need to be complimented. Thank you very much, Dr. Nair, for setting the stage really for this discussion. And you alluded to air travel and of course, your time with aviation. And we in healthcare are now, every conference you go to which is about patient safety, you will have this comparison with aviation. So I did a little bit of a search. So last year, 3.6 billion people traveled in 36 million flights. And the number of accidents is 1 per 2.4 million flights. Now turn to healthcare, 42.7 million adverse effects. So by the time we finish this 60-minute session, 4,860 adverse effects would have happened. And guess what the cost is? The cost in Indian rupees is 7,410 crores for every 60 minutes. So we've got a huge problem. But then let's look at it from another point of view. How many aircrafts in the world? 88% of all aircrafts in the world are made by Boeing and Airbus. And they have 28,241 aircrafts that fly. Boeing has 15, and Airbus makes 10 different types of planes. So let's look at the busiest, the largest airline in the world, American Airlines. They have 946 aircraft and 18 types. Emirates has 245 planes, but only 4 types. There are 7 billion people in the world. Every single individual has his own genome that has 20,000 genes. There are 13,600 confirmed diagnoses that the WHO has defined. There are 6,000 procedures, there are 4,000 surgeries, and I'm sure by next month we would have added a score more. So medicine is very, very complicated, and although conceptually it's very attractive to compare aviation with medicine, you can't really do the comparison because you really don't know how the next individual is going to respond to paracetamol that you might have used for 25 years. Very safely. But that of course doesn't mean that we shouldn't work really hard towards minimizing harm, minimizing errors, because it's our duty as doctors to do that as healthcare professionals. So what really constitute errors in a hospital? In fact, it's really strange, but even today, we will have issues with identification. So you have Mr. RS who needs an adenoidectomy, and you have Mr. RS who needs a urethral stricture dilatation, and Mr. RS with the urethral stricture ends up going to the ENT OT. Ridiculous though it might seem, it happens in 2017. You might actually have 2 urine samples. One is meant to go to virology and it ends up going to microbiology for a urine culture. You have a nurse taking down a result from the lab and she hears potassium 6.6 and actually the potassium is 4.6. She informs the doctor, who then doesn't verify and decides to act on 6.6. It happens. You have a situation where a prescription is written and the doctor, and we all have great handwritings in medicine, instead of 0.5 and you can't really see the decimal, and you end up giving 5 milligrams of something that was supposed to be 0.5. You have errors that happen at the level of dispensing, at transcribing, at prescribing, at administering, and also very important, while we might look at drug-drug interactions, we quite often don't look at drug-diet interactions. And then of course we have a problem with look-alike, sound-alike medication, and that's a very serious problem. And then of course we have issues where the approach to a particular problem might be perceived to have been inappropriate, which then resulted in an error. So this could be about diagnosis. So you decided to do a CT scan, but perhaps if you'd done an MRI, you might have picked it up. So isn't that error? Maybe not, maybe yes. You decide to actually do an intervention, but then when things go wrong, it would be perceived as an error of judgment that why wasn't surgery done? And you go in, minimally invasive, and there is a problem, and then the opinion is that, but the gold standard is open surgery, because if you've done it the conventional way, perhaps you wouldn't have had the complications. So is that an error? So I think the definition of what is perceived as an error by the healthcare professionals is very different to what is perceived as an error by the patient and by the families. Of course, we live in a very a different environment today. See, there's Googleization of medicine. You type diabetes and you get 234 million results. So when somebody with newly diagnosed diabetes walks into an endocrinologist's clinic, he believes a lot of information about diabetes and he questions a lot. And then if the result is not precisely as the patient would have anticipated, well, there would perhaps have been an error. And we've really moved to this situation where everyone really expects 100% success, 100% results. And if we in medicine could guarantee that nobody in our family would actually die or have a complication, but we can't do that. So the perception of error varies between the relatives, the patients, and healthcare professionals, and the society at large. So that's really about errors. Moving on to what Aarti mentioned about what should each organization do to develop really a culture. You can't just do this overnight. It takes a while to develop. But what can you do to build a culture where you recognize that you need to do better today than you were yesterday? So the first thing is to actually recognize there's a problem. And many of us live in denial. You see, everyone who joins medicine super bright, goes through a competitive exam, really does well, believes that they put in 100% every day, do the best for their patients. So is there room for improvement? So Don Berwick had defined these 4 stages when you look at data. So first you say that the data are wrong. I mean, a lot of us do that. And then you say, no, the data are right, but there is no problem. And then you come on to the 3rd stage where you say, the data are right, there is a problem, but it's not my problem. And then you finally accept that the data are right, there is a problem, and it's my problem. So I think it starts with recognizing that it is a problem for everyone in healthcare, because we do have errors that we can prevent. The next thing that organizations can do, and we've done that at Apollo, is that we felt that accreditation would be a good tool. So when we started our accreditation journey in 2003, we actually did a global search and then identified Joint Commission, which is regarded by many as the gold standard. So our hospital in Delhi became the first in India and 6th in Asia. And then 9 of our hospitals are accredited by Joint Commission. Around that time that our first hospital got accredited, NABH was coming up with standards. So we've got 16 hospitals that are accredited by NABH. And NABH or JCI, or for that matter, any accreditation system, does provide a framework to actually make your organization safe through patient safety goals and all the standards and measurable elements that you have to be compliant with. But then once you've done accreditation, you realize that accreditation just is a base. But what patients are really interested in outcomes. No accreditation system measures outcomes. So we at Apollo developed the outcome measurement system called Apollo Clinical Excellence. So we look at outcomes, we benchmark against the world's best published outcomes. This is data we collect every month. It's online, it's audited. This is data that goes to our board every quarter. And we believe that this has helped us become a much safer organization. The next thing is that, okay, you've done accreditation, you have an outcome measurement system, but then your outcomes must get better with time. So your benchmark must be increased, and so you must evolve. And so we went on modifying ACE, which we've done twice, and then developed the Apollo Standards for Clinical Care, which includes all policies, protocols, and everything from handover between nurse to nurse, doctor to doctor, and doctor to nurse to strengthen the system. But I think the final point, which is very, very crucial, is to realize that you have to learn. You have to learn continuously, and you must become an organization that learns. So we as an organization bring experts from all over the world every year for a conference which we call the International Patient Safety Congress, and it gives us numerous ideas that we then roll out in the next year to make ourselves a bit better than we were in the previous year. Thanks, Aarti.
Thank you so much, Anupam. That was very crisp. So now, I just want to shift the focus to reporting and accidents. So suppose nobody comes from home in the morning to say, I'm going to harm a patient or kill a patient. But there could be issues relating to the human being imperfect. Maybe that person is distracted, has had a fight at home, has not been too well, or there is a workload issue, there's too much pressure of work, so there's stress. And due to all the circumstances, this human being makes an error at work and say gives the wrong injection or gives the wrong dose of a medicine and the patient has a serious complication because of that. So my next question is to Justice Vinod Gupta, who is the former Chief Justice of Himachal Pradesh, Uttarakhand and Jharkhand. Sir, how does the legal system differentiate between an unintentional accidental error which has caused harm to a patient versus negligence, and is it liable in the eyes of law?
Thank you. Can you hear me? Sorry. This is working. Thank you. Can you please repeat the sentences you used?
So, in our system improvement initiatives, we like to differentiate between intentional, gross negligence versus an unintentional human error which has landed the patient, caused harm, serious complication, but it was a mistake. There was an error, say a wrong mistake, wrong injection was given. Now, suppose this case lands up in court. Does the legal authority have a difference? Do you differentiate between an accident and gross negligence, is my question.
I was sitting in the audience in the last session which dealt with the Consumer Protection Act issues, and a couple of speakers dwelt on a concept called bona fide errors. In our legal system, intentional or unintentional, these words have been translated into bona fide error or an error based on mens rea. Mens rea is a legal technical term which in plain English means criminal or culpable intention. The most common examples of mens rea or criminal or culpable intention are rash and negligent driving of a motor vehicle. For more than 200 years, the courts all over the world thought that if a driver is accused of rashly or negligently driving his vehicle, the very concept of rashness or negligence cannot import mens rea into it, until in one judgment the Privy Council held that yes, there is mens rea in rash or negligent driving also, and the Privy Council, it defined the mens rea like this. It said, a driver by rashly or negligently driving his vehicle knows that this may result in an accident, but he hopes that it may not. Knowledge is there that this may result in an accident, but he is still driving it with a hope that it will not. That is mens rea in the term it is used with respect to such acts which invite action for compensation or for damages. Now, in the medical field, which is very different from rash or negligent driving of a motor vehicle, in the medical field, in most of the cases, perhaps, a doctor cannot be accused of willful or intentional negligence, because in medical field, if a doctor is accused of willful or intentional negligence, it's a very serious matter. Willful, intentional negligence with respect to the treatment of a patient is a very serious matter, because if such a negligence results into death, the charge may be as severe and as grave as murder. Most of the cases that we come across are bona fide mistakes. Bona fide mistakes can be galore, there can be many, and as the journal made a presentation, they can be for a variety of reasons. Not well qualified, not well trained, not well educated, not well experienced, busy, not very well attentive, host of other issues. If the patient complaining of any damage to himself because of an error on the part of the doctor, if he can prove that it was an intentional, deliberate act of negligence or rashness, the doctor will be in a lot of trouble. But if on the other hand, the doctor can prove that it was a bona fide mistake in the normal course of discharge of his professional duties, then the courts cannot hold the doctor liable for any compensation or any damage.
Thank you so much. I think that would be quite reassuring to all the audience sitting over here, because the healthcare industry is getting more and more defensive and living under a huge public threat. So going forward, my question next is to Dr. B.K. Rao, Chairman of Gangaram Hospital. Dr. Rao, this is about bringing out issues, errors that have happened, and what are the consequences in today's scenario in India about openly reporting an error, and people are very scared of openly bringing out issues because of the punitive actions that come about this. How has your organization addressed this to some extent? Do you have a system where people are openly reporting, and how do you bring in accountability to those problems which have been surfaced? Are you soft on the issues? Do you look at it from a system perspective, or do you make individuals accountable?
We treat every report as a learning exercise. The purpose of admitting a mistake or an error is not for the person reporting. He does not want to be penalized. And the person who's hearing it out, that is the organization, it is not an opportunity for them to take it out on the individual or to hear it and forget it. So they should not take this as an opportunity to hide the facts, neither the individual nor the organization. So this is what we do. We do not penalize. We have a system in place where people are encouraged to report, and each report is then individually taken up. We go into the root cause analysis of that as to what caused it in the first place, and what is it that we can do so that it does not get repeated. More than that, we even share it with whatever forum we need to, so that other people also get educated and they also have the benefit of knowing that such a thing can happen, so that not only us, even the regulatory agencies, even NABH and other hospitals should also know that such a thing is possible, because that reminds me of one fact. What we all know is the Murphy's Law, which says that if anything can go wrong, it will. So the fight is actually between what can go wrong and what is going wrong. And in this fight, we have heard that, humans are infallible or not infallible. The err is human and we will commit mistakes. Yes, the idea is to contain it to the lowest possible, and that is where we also encourage that all our service providers, doctors, nurses, and others also know what is expected out of them in the first place, so that they don't make mistakes in future.
Excellent, Dr. Rao. It clearly shows that you've made a lot of progress with building trust and transparency amongst your staff and partners in your organization. So the last question for the session is to Dr. Girish Tyagi, the Registrar of Delhi Medical Council. It's a privilege to have him here, and he sits many times on the opposite side where he has to deal with a lot of complaints against hospitals and mainly doctors. So, this whole being a partner in the entire process of patient safety, How does, and you know that the World Health Organization has clearly come out with saying that any mistakes that are happening in the industry should be dealt with in a non-punitive manner first. So you're sitting as a regulator. The hospitals, say Dr. Sibal, Max, Gangaram, and many others, when an error happens, they look at it with a non-punitive eye to learn. All of them have repeatedly said, we take every mistake that has happened as a learning, and we don't take individual action. We take systemic action to improve the system. Otherwise, actually, if we, otherwise every staff members at some time or the other would have made a mistake and they would all be, behind bars or facing severe punitive action. So has Delhi Medical Council as a regulator, imbibed some of this culture into looking at it through a lens that the industry wants you to look at or the World Health Organization wants you to look at in terms of, blame-free versus where do you draw the line?
Thank you, Aarti ji. Thank you, Shri Shakti Gupta ji and Mr. Dr. Satpathy for making this a memorable conference. As far as the blame-free system or blame-free, as WHO has also recommended that blame-free system should be there and there should be no punishment. But in our system, Mr. Nair also told, Dr. Nair, that nobody wants to take the responsibility. And ultimately is the patient-centric. We want the safety of the patient and for the benefit of the patient. Just I'm enumerating one case. In a North Delhi corporate hospital, big hospital, NABH accredited hospital, young patient admitted to the hospital for the surgery of the ankle. Wrong patient was marked, going to the OT, wrong surgery was done, and it was not, after the OT, the patient came out of the OT, patient told the doctor and the hospital that the wrong surgery has been done. All the NABH accredited surgery checklist was there, all the parameters was there, but nobody was looked after that. And Dr. Kantikar was there as regards the record keeping. There were a lot of manipulation in the records. How can you justify that? A young patient going to the surgery, wrong surgery is done, and nobody want to take the responsibility. Hospital just want to just shed off the responsibility, punish those two doctors. Then of course these two doctors are not allowed to work at the hospital. They might be working at them. Then nobody will regulate that. Maybe the medical council of India, the medical council, or the criminal court or the consumer court. At least these cases, these type of, and this is not the one of the cases only.
So these are exceptional cases.
These are exceptional cases.
Exceptional outliers which do deserve some kind of
if there is
action.
A blame-free system is there, then of course the medical reporting of the cases will be there. When the reporting of cases is there, then the system will be in the place, then we can identify the error, and of course the system will be, we will try to improve the system, of course, then it will. But as far as because it is a closed meeting, most of the doctors are there, litigation against the doctors or the medical establishment are basically, we have, in Delhi Medical Council, we have come to the conclusion that only two things are required: communication and documentation. If our doctors as well as the other professionals use these judiciously, litigation will be reduced to the minimum. Communication, we don't to try to communicate with the patient or to the patient relative. We don't to tell the patient about the prognosis, and at the time of the death, it is a scene that the lowermost person in the government sector, it is some of the time only the nursing orderly is declaring the death of the patient to the relatives. Then of course these all assault against the doctor and the medical professional, it is on the rise.
So I think, yes, very nicely put. It's very important that this trust deficit which we are facing from the public can be greatly improved just by being close to the patient and their family and talking to them at each step of their care. And that will not break the trust.
Yeah.
and really improve things. So I think we'll come to in the interest of time. There were many things that we would like to discuss, but in the interest of time, we would like to now open the session for questions from the audience, if any, to the experts. Yes, please. Can you have the mic? You'd also like to please specify who you are addressing the question to. After him, then, yeah, let him take, then you can take, Sanjeev.
Open to House, I'm Brigadier Pradeep Sharvastava. Just want to tell one thing. These cases which are being recorded in various hospitals, now these things we do not come to know about, and to various other people are not coming to know about this. Can we compile these and have, like a lawyers, they compile a booklet sort of thing where, and we can refer these things so that the hospitals are benefited out of this?
I think that's a very good, Anupam, would you like to? Or?
I mean, that's a great suggestion, and I think in Delhi we can request Girishji to do that, because they have access to all this. What we get access to is by word of mouth or from newspaper stories, or, you know, if it happens where you are in the know of things. But I mean, every complaint goes to you. I mean, if a handbook could be created, I think that's a great suggestion.
To take out the learnings from that. So that's a great takeaway from this.
Can I add to that? We talk of medical errors only, but really speaking, there is very little in the public domain on that, or even in the scientific literature, because we know the problems of reporting is there. But let's talk of disease management and let's talk of outcome management, because ultimately if we know that the mortality has come down, the morbidity has come down, so obviously there are things which we are doing right, which we were not doing right previously. So this disease management data and the outcome management data is in the public domain by most of the big hospitals, so to share with others. So that can be accessible to others.
Wonderful. I think this is a very good suggestion, and we have, you know, doyens like Dr. Shakti Gupta, who's really leading on a very neutral platform. So maybe your organization, your research organization, the NGO, can take up such initiatives and be very neutral and help collaboration to grow amongst the industry. So thank you for that. We'll take another comment or question.
Good evening. I'm Dr. Sood. When we talk about patient safety, the Institute of Medicine has recognized never events, which are defined as medical accidents or errors which are eminently preventable. So there are about 27 of them. So as a medical community with sufficient confidence, we should resolve that at least these never events like wrong side surgery and surgery in a wrong person never occur. And certainly we can't have an entirely blame-free culture, and these will be drawing the liability on the part of the individual and will also amount to medical negligence. So first we should hit at the never events and resolve to make them totally preventable.
I think that's coming out from all the panelists also. Any other question, please, from the audience? Okay, if that's, I would like to then say thank you to the expert panelists who have been here and given their precious time for this session. And we'll just summarize that there is a need for an emphasis on training, standardization, learning continuously, collaborating, and measuring ourselves and continuously raising the bar. And we should be very, very open to be owning the liability and the accountability for errors that happen. But of course, the emphasis should be on prevention, not so much on facing the consequences of an error. In the legal parlance, they are sympathetic, but yes, if a patient has been harmed, there's no running away from legal liability is what has come out from this session. So with that, I'd like to thank everyone for the session.
He took over from me, sir.
Thank you, esteemed panelists and chairperson, for this enriching session. I now invite Lieutenant General Velu Nair to kindly felicitate the panelists. I invite General Velu Nair to felicitate Justice Vinod Gupta.
I was fond of Justice Leela Seth.
Okay. She was my predecessor in Himachal Pradesh.
Yes, sir. Come. Come, sir. Please.
Dr. B.K. Rao.
Clapping makes you happy and smile. Yeah. And it will wake you up.
Dr. Anupam Sibal.
Her husband was working with Bata shoes.
I know.
And
I have been to her house in Noida.
yeah. And
Dr. Girish
he
Tyagi.
went on after Bata, he was working with a very dear family friend of ours. So that's where I started knowing him. I know Mrs. Seth through her husband.
She came to me, she was Chief Justice in April.
I request General Nair to felicitate our moderator for this session, Dr. Aarti Verma.
So did you see, sir?
May I now request Professor Siddharth Satpathy, sir, Head Department of Hospital Administration, AIMS, to felicitate our chairperson, Lieutenant General Velu Nair. I request all panelists and chairpersons to assemble for the group photo.
83 onwards.
Sir, group photo.
Yeah. Most of us have grown together. He came, I think, in 84. Rana came in 82. Yeah. From Himachal. He came 2 years before me.
Thank you.